Good afternoon, everyone. Welcome to our second to last subcommittee budget hearings. I know you're going to miss us so much. I'm Delegate Emily Shetty. Welcome. Today is February 29th, and we will be hearing from the Maryland Department of Health on the Behavioral Health Administration budget. Before we kick off, I just want to take a moment to share, I think some of you who heard on the floor today, we are joined by some really special student shadows. And so I have a shadow today, and he is joining us here. This is Antonio Luna. He is a junior at Mount St. Mary's, and we're really excited that he can join us for the budget hearing today and learn all about behavioral health. So as we always begin, we will kick it over to Naomi Kimura, our budget analyst, for her review. Thank you. You can begin when you're ready.
Thank you, Madam Chair. My name is Naomi Kimura. I'm a budget analyst with DLS, and I'll be presenting the budget for the Behavioral Health Administration under the Department of Health. So the fiscal 25 allowance includes $3.2 billion in the Behavioral Health Administration, which is $130.7 million lower than the fiscal 24 working appropriation. On page 4 begins discussion of a few different performance measures that MDH includes with its annual Managing for Results data submission. The first is around the total number of people receiving behavioral health care services in the state. The exhibit on page 5 shows the number of individuals treated by the different categories that MDH reports utilization by. So there's the total number of individuals with mental health diagnoses, individuals with substance use disorder diagnoses, and then those who are diagnosed dually. The number of people with mental health diagnoses that are treated has been increasing since fiscal 2020, but among people who have been diagnosed with substance use disorder or dually diagnosed, the amount of people seeking treatment decreased from fiscal 22 to 23. MDH also estimates the amount of need in Maryland among adults and children for behavioral health care services. Exhibit 2 on page 6 shows the percentage of people that are treated out of the number of individuals estimated to need or want treatment, separated by children and adults. And in both of those categories, the percentage of people accessing care has been increasing between fiscal 2021 and fiscal 2022. The second performance measure I'm going to discuss is telebehavioral health usage. Language in the fiscal 24 budget bill required MDH to start including statewide utilization data of telebehavioral health services with the submission of the fiscal 2025 MFR data. And this data has shown a sharp increase in utilization of telebehavioral health services following fiscal 2019. This is due in part to the ability of providers being able to bill for audio-only telehealth services as of 2021, as well as increases correlated with the COVID-19 pandemic when people were utilizing more virtual care. Because of the quality of the data submitted, the Department of Legislative Services recommends the release of the $100,000 in general funds that was restricted pending this report, and if there are no objections raised by the subcommittees, we will process a letter to this effect. Finally, I'll just talk briefly about the utilization of medication for the treatment of opioid use disorder, or MOUD. MOUD is offered mainly through opioid treatment programs throughout the state, as well as correctional facilities, recovery residences, and pharmacies. Exhibit 4 on page 8 shows the number and the proportion of people that receive substance use disorder services and the percentage the proportion of those receiving services that are also receiving medical treatment. So between fiscal 2020 and fiscal 2023, the total number of individuals receiving substance use disorder care has been decreasing. And from 2021 to fiscal 2023, the proportion of those people receiving MOUD has also been decreasing. There was also language in the fiscal 2024 budget bill restricting funds pending a report on MOUD, which BHA submitted. Exhibit 5 on page 9 shows the prevalence of MOUD and oh, excuse me, this is a typo. This is actually showing the supply and demand for opioid use disorder treatment in Baltimore City and the counties across the state. And so you can see there's quite a bit of variation in the availability of providers across different jurisdictions. And so DLS has asked MDH to comment on its work with individual local behavioral health authorities to address insufficient supply of MOUD services in their jurisdictions. Page 10 continues the budget discussion, starting with reversions from fiscal 2023. At the closeout of fiscal 2023, BHA reverted more than $100 million in general funds. $35 million of this was related to crisis response programming, which is also budgeted in the fiscal 24 and the fiscal 25 budgets. These programs required developing new regulations in order to be eligible under Medicaid, and this process took longer than anticipated, and so MDH reverted the funding at the close of fiscal 23. I will talk in a couple minutes about their progress in this process and what they're doing with the funding in fiscal 24. The other reversion that I wanted to note is $2.5 million for the Sheila E. Hickson Behavioral Health Services Matching Grant Program. BHA reverted this funding in fiscal 23 because it was unable to adequately staff the program. The fiscal 25 allowance includes $2.4 million for the program, and so we've asked MDH to comment on if it's been able to adequately staff the program as of the 2024 session. On page 11, we've listed out some of the proposed deficiencies included in the fiscal 25 allowance, which increased the fiscal 24 appropriation by $438.2 million. This is mostly related to addressing shortfalls in Medicaid, behavioral health Medicaid services, and partially offset by withdrawal of $74.4 million for provider reimbursements in community services for Medicaid eligible, the Medicaid eligible population, and community services for the uninsured population. The pie chart on page 12 breaks out behavioral health spending on provider reimbursements, which makes up about 87% of the total budget for BHA. Most of this is dedicated to behavioral health related Medicaid services, reimbursing providers for those services. There's also about $107 million for provider rate increases, which includes the 3% discretionary rate increase and the annualized 8% rate increase effective January 1st, 2024. The next pie chart on page 13 breaks out the spending outside of provider reimbursements. So that total is $421.4 million. And you'll see included in this are the grants and contracts with core service agencies that are providing services at the local level, as well as new behavioral health investment spending at $89.2 million, which I'll talk in more detail about in a second. There's also $32 million for the contract with the Administrative Service Organization. On page 14 and 15, we've broken out the major changes in the budget from fiscal 24 to 25. Again, the total budget is decreasing by about $131 million. This decrease is offset partially by an increase in personnel costs for new positions that are being added in fiscal 25, as well as an increase in the 988 trust fund to meet the $12 million mandate established in the 2023 session. Some of the big decreases are related to provider reimbursements, which would reflect an estimated or projected decrease in Medicaid enrollment and utilization in fiscal 2025, as well as a decrease due to one-time expenses related to the behavioral health investments in fiscal 2024 that are not continuing in 25. On page 16, we've noted two areas in which the fiscal 2025 budget bill has included language authorizing the transfer of special funds to BHA from other offices in the Department of Health. The first is related to the Senior Prescription Drug Assistance Program. The fiscal 25 budget for BHA includes $5 million originating from the SPDAP balance for behavioral health services. Statute does not allow this use in fiscal 2025, and DLS has a few different recommendations related to this. So the first is we've asked BHA to comment how these funds will be used to support behavioral health services in BHA. The second is to allow use of these funds under BHA. We've recommended adding a provision to the BRFA of 2024 in order to authorize the use of this fund balance for behavioral health services. And then finally, we've also recommended adding language making the $5 million contingent on the BRFA, including the provision that I just mentioned. The second, related to the transfer of special funds, is a contingent reduction. The 25 allowance includes language that would reduce $3 million in general funds from the Community Services Program, contingent on legislation that would authorize the transfer of excess special fund balance from 3 different boards in MDH. We've asked BHA to discuss the planned use of these funds in BHA and when it anticipates the funds would be added to the BHA budget, because they're just not included in the 25 allowance for BHA. The next topic I'll talk about is the Assistant Outpatient Treatment Program, which is being considered by the General Assembly now. The fiscal 25 allowance for BHA contains $3 million contingent on legislation that establishes county grants for these programs. However, the legislation as introduced does not establish county grants for the program, and so DLS is recommending amending the contingent language by just removing the reference to county grants. In addition, DLS has a few concerns about the amount of effort that this legislation would require by local governments and the amount of money that would require to fulfill those mandates. And so we have asked MDH to describe the specific uses of the $3 million that would be included in the fiscal 25 allowance, indicating where that money would be directed and for what purpose. And we've also asked MDH to discuss any other funding sources that it plans on leveraging to supplement this funding for these purposes. Next, I'll provide a brief update on behavioral health provider reimbursements. I mentioned earlier that the fiscal 2025 allowance includes $107 million for provider rate increases. This includes that 3% discretionary increase, as well as the annualization of the 8% rate increase resulting from the increase to the minimum wage passed last session. DLS conducts annual forecasts in BHA and in MCPA to understand the adequacy of funding included in the budget to sufficiently fund Medicaid related services. On page 18, Exhibit 9 shows the DLS projection of need compared to what is budgeted. And so in fiscal 25, DLS projected surpluses in the behavioral health services for the uninsured population. And then in fiscal 24 and 25, we've projected smaller surpluses in the community services programs for the Medicaid eligible population. Despite forecasting some surpluses in some of these programs, we're not including a recommendation to reduce funding because we believe these surpluses could be used to reduce shortfalls in the medical care programs administration. Okay, page 20 has personnel data. So again, in fiscal 25, BHA is adding 69.5 new positions, which includes 20 that were created by contractual conversion in fiscal 2024. We've asked MDH to discuss the planned uses of the new positions. Secondly, BHA, as of December 31st, 2023, had 39 vacancies, but this data appears to include 19 new positions that align with the contractual conversions that I just mentioned that were authorized in fiscal 24. The remaining 20 vacancies exceeds the number of positions needed to meet their budgeted turnover in fiscal 25 by 7.5 positions. And of these 20 vacancies, 9 have been vacant for more than 1 year. And so DLS has asked BHA to comment on efforts to fill and or reclassify long-term vacancies. Next, I'll begin discussion about the BHA investments that I've been mentioning. So in fiscal 24 and 25, BHA has included significant investments for new behavioral health initiatives as well as the expansion of existing initiatives. The fiscal 24 working appropriation includes $107.5 million for these efforts. The fiscal 25 allowance includes $89.2 million. Included in both of these amounts is $35 million for crisis response services, which I mentioned earlier. MDH provided an update on where they're at with the licensure for Medicaid regulations. They said that the licensure and Medicaid regulations were published by the Division of State Documents on February 9th and are currently under public comment. We've asked MDH if they could provide a more exact date when providers will be able to start billing for this service. On June 28th, BHA submitted a report in response to language in the fiscal 2024 budget bill restricting funds, requesting a report on the planned uses of these investments. Exhibit 10 on page 22 shows where BHA planned on spending this money and where they actually have been spending it in fiscal 2024. Most of the spending has remained consistent with the plan, but in the last 6 months there have been a few shifting priorities, mostly related to programs that are just going to be funded one time in fiscal 2024 rather than be ongoing annual expenditures. On page 23, this bulleted list includes some of what these behavioral health investments has actually gone to fund in fiscal 24, included the expansion of assisted living slots, additional permanent supportive housing slots, and additional residential rehabilitation program beds. We've asked MDH to explain the cost of these investments thus far in fiscal 2024 and comment on how they align with projected costs presented in their July 2023 report. Exhibit 11 on page 24 shows the breakout of the fiscal 25 funding based on how MDH says they will be spending the money. More than half of this funding is dedicated to crisis response programs, and included in that is the $35 million that MDH is going through the process of approving the regulation to have these services be reimbursable. In the meantime, MDH has been using this funding to provide one-time grants to providers that are already providing crisis response services across the state. We have asked MDH to comment on what portion of this $35 million is dedicated to grants and how much of it will be used for provider reimbursements in fiscal 2024, as they project that toward the end of the fiscal year, they'll be able to start reimbursing providers for this service. On page 25, I'll just briefly talk about the Commission on Behavioral Health Care Treatment and Access because it is influencing how BHA is determining where to put these investments. This commission was established in 2023. MDH has been staffing it and started convening in the fall of 2023. The commission was established in order to assess the public behavioral health care system and come up with recommendations to strengthen it and identify where funding should be directed. Part of the Commission's work is to conduct a needs assessment of various elements of the public behavioral health care system, and the Commission does its work through 4 different work groups. The Commission submitted its annual report in December of 2023 and shared some of the recommendations that are listed toward the bottom of page 25. Part of the Commission's work is also to evaluate funding investments under behavioral health at the Behavioral Health Administration in relation to BHA's continuum of care, which is presented in Exhibit 12 at a less detailed, higher level. And so this exhibit is showing where of the fiscal 2025 investments, where funding is dedicated on this continuum of care. And so, of course, a lot of the funding is under the urgent and acute care, driven mostly by the $35 million in crisis services. And so DLS has asked MDH to comment on the Commission's activities that are examining the adequacy of funding for some of the other areas on the continuum of care, particularly around prevention, education, and promotion, and early intervention efforts. The last update I'll provide is on the Administrative Services Organization. So, as this committee knows, there were complications with Optum, the last ASO provider, or the current ASO provider, related to how providers were reimbursed There were issues with the accuracy and the timeliness of reimbursing providers, which led MDH to then provide estimated amounts of payments to their providers that were providing services across the state. This resulted in overpaying some of these providers and MDH needing to recoup those funds. And so MDH has been working for the past couple years to do this. As of February 15th, 2024, the outstanding balance of money to be recouped was $52.7 million, which is compared to the $300 million that was estimated, the estimated balance in fiscal 2021. MDH anticipates completing the recoupment process by June 30th of 2024. Language in the fiscal 2024 budget bill restricted funding pending a report on the recoupment of overpayments and forgiveness of some of these overpayments. But as of February 15th, MDH had not yet submitted this report. And so DLS is recommending adopting budget bill language restricting funds pending submission of the report. There's also an update on a new administrative services organization. MDH released an RFP in January 2023, and on February 14th of this year, BPW actually authorized a new ASO contract with Carillon Behavioral Health. The contract begins March 1st, 2024, and ends December 31st, 2029, with a two-year renewal option. So this concludes the analysis. In closing, I'll just go through briefly DLS's recommendations. We have recommend restricting funding pending the submission of 2 reports. We have one recommendation to amend language related to the Assistant Outpatient Treatment Program. And then there's also 5 pieces of annual language related to authorizing the transfer of funds between behavioral health programs, as well as one program under MCPA. I'd be happy to take any questions if there are any.
Thank you so much, Ms. Kimura. Do any subcommittee colleagues have any questions? Seeing none, thank you so much for your incredibly thorough analysis and your presentation. So we will now call up our department witnesses. Secretary Herrera-Scott and your team, please join us. You may begin when you are ready. Thank you. And before we begin, I just want to publicly thank you. I know we corresponded as well, but thank you so much for getting the agency responses to us well before the 48-hour deadline. We had them a couple days before the DLS analysis. So it was great. We were able to...
we wanted to make sure we didn't mess up again.
You were awesome. We really appreciate it.
Well, we still have one more budget hearing, so there's still time. So just wanted to... Good afternoon, Chair Shetty, members of the committee, Laura Herrera-Scott, Secretary of Health for the record. We're excited to be here to talk about the Behavioral Health Administration budget. And with me today is Deputy Secretary Alyssa Lord, who's been with the department since the end of August, and you'll hear a little bit more about her in a minute. But before I turn it over, did want to say, you know, in addition to all the other work that you've heard from the department, behavioral health has certainly been a priority for me personally because of the crisis that we're in. And very early on, just months after I started the role, I really didn't understand the landscape the way I do on the physical health side. And I said I really wanted to understand what we were providing and where we were providing it. And we pulled all claims for 2022 and then in the last few months, 2023, because I didn't have full claims run out at the time. And I said, I want to know every single service we're paying for and where we're paying for that service and who we're paying it for. So we looked at the data, mapped it out across the state. We also did that for our grants. And what we started to see was what I refer to as the white space. Where aren't we providing services? And I think some of you have heard me before. We quickly learned, for example, that if you are an adolescent in the state of Maryland and need inpatient substance use treatment, we do not have anything to offer you in the state of Maryland. So what you'll hear today from Deputy Secretary Lord is just the intentionality that we are moving now based on that white space. But we've mapped it out by county. We've now mapped it out by adults and children because children are even harder for a variety of reasons. And we also have mapped it out by race and ethnicity. And as you can imagine, our Black and brown citizens of Maryland, access is even more problematic. So just wanted to set the stage for a lot of work that happened last year to talk about where we're going. but we are being more intentional than we've ever been with behavioral health dollars. So did want to share that. With that, I'll turn it over to Deputy Secretary Lord.
Thank you, Secretary. And good afternoon, Chair Shetty and Budget Subcommittee members. I want to thank you all for your time today to talk about the Maryland Department of Health's proposed budget for behavioral health and the alignment of funding to support the Moore-Miller administration's priorities to achieve an equitable, world-class, high-quality healthcare system that provides whole-person care and treats everyone with respect, compassion, and delivers on improved health outcomes and experience. My name is Alyssa Lord, for the record, and I have the privilege of serving as the Deputy Secretary for Behavioral Health. I'm here today to share our commitment to Marylanders to put solutions in place to strengthen our behavioral health continuum of care. There is a slide in your deck that represents the framework for a patient-centered model of integrated mental health and substance use care, also known as the continuum of care. As the Secretary mentioned, this model evolved after an extensive review of claims and utilization data to understand the current utilization of services, as well as identify opportunities for investment in services. For context, and as you heard from Ms. Kimura, in 2023, more than 318,000 Marylanders access mental health services and substance use services. The state actively engages our local partners and stakeholders to assess and evaluate core programmatic needs within the continuum to sustain or to bring to fruition. As such, this has led to the recognition that we need to, at a minimum, further define a strategy for children, adolescents, and families, inclusive of revamping our current 1915I initiative and reestablishing adolescent inpatient SUD services, provide additional focus on veterans, older adults, problem gambling, and suicide prevention, and expand housing and transitional community-based care from facilities such as residential rehabilitation and assisted living programs. The governor's fiscal year 25 allowance adds 69.5 new positions for BHA. This includes staff to strengthen BHA's efforts to ensure quality of behavioral health services through licensing and compliance activities, crisis services, housing, and shoring up BHA's fiscal and procurement infrastructure. We are also working to fill long-term vacancies, including the Director of Finance and Fiscal Services, and we are interviewing 4 candidates in the next couple of weeks. On February 14th, BPW authorized a new ASO with Carillon Behavioral Health. Also, as you heard from DLS, that contract begins on March 1st, 2024, and ends December 31st, 2029. Carillon is slated to go live January 1st, allowing for a 10-month period of design, development, and implementation. The recoupment forgiveness process currently related to the current ASO is still ongoing with a June 30th, 2024 timeline for balance reconciliation. I would like to take a moment to recognize the governor's commitment to and investment in behavioral health. The governor's fiscal year 25 allowance provides a 3% cost of living adjustment for behavioral health providers to ensure we have the workforce needed throughout the continuum of care. I would also like to acknowledge the $89.2 million in the fiscal year 25 budget to continue behavioral health investments in Maryland that were started with the $107.5 million in the fiscal year 24 budget. There are several initiatives funded in fiscal year 24 that will continue to be funded in the fiscal year 25 budget. This includes statewide expansion of the collaborative care model, mobile crisis and crisis stabilization reimbursement, and as you heard, our regulations are out for public comment with that feedback due March 11th. And then community placements of individuals discharging from the Maryland Department of Health healthcare system, such as crisis respite beds, tertiary beds, and permanent supportive housing. I want to thank you for allowing me to speak today on the importance of the behavioral health continuum of care and how we can move forward together. With that, I will turn to provide a brief highlight of our written responses to the DLS questions. In the interest of time, I will focus on a few of our responses, but happy to take any questions after. Regarding vacancies, BHA is actively working to address and remediate vacancies through increased and improved coordination and a continuous review process. Regarding Billing for mobile crisis and crisis stabilization centers. We anticipate providers to begin billing for these services in late fiscal year 2024 and an increase in billing in fiscal year 25. We are also pleased to share that $13.5 million in grants were recently awarded to support mobile crisis and crisis stabilization centers. Regarding the $107.5 million in behavioral health investments as represented in the 2023 JCR, the funds currently support initiatives that are underway, including crisis services, collaborative care, tertiary care, and hospital discharge initiatives. Lastly, we thank DLS for the recommendation for the budget lock to provide the flexibility needed to ensure the department can target budgeted resources where they are needed and to address any potential deficits. And with that, I am happy to answer any questions.
Thank you so much, MDH team. Appreciate it. Any subcommittee colleagues have questions for MDH? I can start if needed. Okay, I want to kick off with a question about the ASO contracts. So as mentioned by our DLS analysts and in the analysis on page 28, Carillon Behavioral Health is a slightly more expensive contract than Optum's, but we all know of the significant challenges that Optum had, and so sometimes it's important to pay for the assurance that we don't have some of the same challenges we had before. There's some overlap budgeted to cover both contracts in the first half of FY25. So how is the work with DBM going to ensure that the expenses are covered for the new ASO?
So we just started those discussions since it was just awarded. We would have to get back to you on that. We're still, solving that because we do want to make sure part of the issue with Optum going live is that there wasn't enough transition time between the prior ASO Beacon and the move to Optum, and we want to make sure that that does not happen again with this trend.
Great. Thank you so much, Madam Secretary. Delegate McCaskill for a question.
Thank you, Madam Chair. Sorry, I was trying to get my red pen out for the response.
I'm with you on the red pen.
It makes a difference in life. So I am going to go to the decrease in Medicaid enrollment. I'm referring to page 13. And so in your DLS analysis, it notes a decrease in funding for provider reimbursement in a tune of, $205.8 million due to the decrease in Medicaid enrollment as the public health emergency expansion comes to an end. So could you please comment on the BHA's plan to do, what you plan to do to ensure Marylanders continue to receive their needed behavioral health?
So I'll start because we've had just to go through the numbers again. So, we took the 12-month option for Medicaid redeterminations. We are disenrolling approximately 20,000 people right now a month based on procedural and no longer Medicaid eligible for Medicaid. As far as the behavioral health system of care, there's always been state funds for supportive care in the public behavioral health system. So those people that still need services in behavioral health can still access those services in behavioral health, even if they're no longer eligible for Medicaid.
Okay.
You won't see it in these numbers, though, because at the time that these numbers were pulled,
great.
people were still enrolled in Medicaid.
Okay. All
Great.
right.
Thank you. Do you have a further question? Yes, please.
For
go
my
ahead.
last bite at the apple.
Of course.
For the day, I think. So this is about the personnel vacancies. And I just had one quick question. Page 20, I was looking at. So I thank you for providing an update in your submitted testimony about your efforts underway to fulfill personnel vacancies. So on the DHL analysis, there's a mention that BHA recruitment efforts have been underway since January 2023. So I'm specifically referring to page 20, but my question is, I didn't notice an update about the positions in the testimony, so could you just give us an update on the position for Chief Financial Officer, the vacancy there?
Happy to. So we currently have 4 interviews that are scheduled over the next 2 weeks for that position.
Okay, good luck. Wish you the best with that.
Thank you.
Thank you, Madam Chair.
Can I just add to that?
Yes,
The department had a history of only posting online and recruiting internally in this state, and we are actually using talent managers now to help bring people attention to our positions, and we've used it for the first time with the CFO and now have 4 qualified applicants, so we will be changing the way we recruit, especially for the senior leadership roles that we have at the department.
That's terrific. Thank you. Thank you for the questions and for the update. Vice Chair Jones.
Thank you. Good afternoon. All right, let's flip over to page 10. Let's take a look and go through $100 million reverted back to the general fund from FY23. Okay. Any details that you could provide across the first 5 bullets that were not addressed in your testimony, that would be great. Is there anything we could drill down on a little bit more?
I mean, it's all listed there. The biggest reason for the reversion was the crisis not going live. When I got to the department, we had just put out the regulations, and we heard loud and clear from the providers that the rates that were in the regulations were absolutely inadequate for them to go live with crisis services.
Okay, thank you. Well, for example, the $9 million for grant programs. So yeah, there's like 3.5 for interagency hospital overstays initiative. It's not leveraged.
Yeah, it wasn't. We put the RFP out 3 separate times, and no one bid on the dollars. Again, the children that we're seeing are the acuity of the children that we're seeing is more than we've seen in years, and we unfortunately did not get any takers to the RFP that we put out 3 times.
Okay, thank you. So the pediatric primary care program, that was never initiated, right? The Maryland Behavioral Health Pediatric Primary Care Program.
No, that was not initiated. What we've done is, now that we've gone statewide with the collaborative care model, which is embedding behavioral health assets in primary care, the collaborative care model is inclusive of pediatricians. So that's now part of the collaborative care model.
Okay, thank you. One more. Let's go to page 36 together. On page 36, Appendix 2. All right. So this is an analysis of the proposed bed registry and referral system. Obviously, this is an absolutely critical project that will help better coordinate patients in need of behavioral health services, right? And it ensures that they're able to access appropriate spots for the needs in real time. DLS notes that there is a significant risk in the cost of this initiative since the cost of the system is unknown and there is no further funding plans past this year. Could you please provide details on what BHA is doing to mitigate the risks outlined by DLS to get the system operational?
So we are currently in the process of working on finalizing the RFP, and we will be seeking proposals to understand both the cost, both at the onset as well as the ongoing implementation.
And I'm sorry, when will the RFP be finalized?
We are currently working on it now.
And then when do you expect for that to go out, or?
Probably by the end of the fiscal year.
End of the fiscal year? Thank you. Madam Chair, thank you.
Okay, Delegate Heimbach. Thank you, Vice Chair Jones.
Oh, thank you for your testimony, first of all. And I want to say it's very encouraging to see the investment in behavioral health. There's obviously, we all recognize the need there. I have a question at the very top of page 14 of the DLS analysis. It mentions that you're in the process of renewing the federal state opioid response grant, which is expiring. I think that was $23.6 million. It says, I believe it says in there that you expect that grant to be approved in this FY, I believe. I'm just curious, is that still your expectation?
It is, and we are currently awaiting word regarding SOAR 4, and in anticipation of that, we just released a request for expression of information to more than 1,100 community stakeholders to be able to apply for those dollars. Obviously, it's contingent upon funding, but the federal government has continued to fund SOAR for the past several years.
Thank you.
And I will just say, the news today was that they came to consensus at least to fund the federal government to the end of the year. So at least we're hoping to get SOAR 4 as now. I think part of the holdup has been the continuing resolution and what the federal government was doing around that.
Yeah, thank you. Do you anticipate it will be the same amount of money or more or less? Or
That's certainly what we're planning for. We've gotten no indication from SAMHSA that it would be less.
okay, thank you. Thank you, Madam Chair.
Thank you, Delegate. I have a final question that's slightly outside the budget, but is very relevant to the work that you all do. And it's related to the issue of prescription drug shortages, specifically for behavioral health prescriptions. So the American Psychiatric Association reported recently, last summer, to Congress that 99% of patients are struggling to get their prescription drugs in classes like stimulants, benzodiazepines, and antipsychotics. These issues are still ongoing. When you look at the news, I'm hearing from constituents, and my own family has sort of struggled with this as well for a prescription for my child that's needed. And, you know, it's not even just the brands, it's now like all of the classes, all the generics. It's just, it's a really big issue. And I know that there, you know, really needs to be a coordinated federal response to this, as it's primarily an interstate commerce issue and potentially a global supply chain challenge issue. But I'm wondering if there's anything our state can do, and we could take this response offline to really brainstorm together what we might be able to do here in the state. And I don't know, I haven't honestly been able to come up for air to research whether other states are doing anything interesting on this, but would love to work with you on this issue.
Absolutely. So as you said, unfortunately, it's a national issue. It's not unique to Maryland. It's certainly something we're watching closely and trying to understand the impact of people not having access to their medications and the downstream impact of that. So we welcome the opportunity to sit with you and talk about what we could do differently, if anything.
Great. I would love that opportunity. Okay, thank you. I think that concludes the questions for this panel.
Can I forgot to thank Naomi.
Oh,
I'm so
yes,
sorry from
please.
the beginning. So
Always,
thank you so much,
always
as
welcome.
always, for the detailed analysis. We really appreciate always your insights, and it certainly forces us to look at the budget differently. So thank you.
Thank you, Madam Secretary. Thank you so much. And thank you, Deputy Secretary, for joining today as well. It's really nice to meet you. Okay, we will now proceed with public testimony, and consistent with committee guidelines, members of the public have 2 minutes each to share their oral statement with us. We'll call 4 people up at a time. You may seat yourselves however you wish, and you can proceed when you're ready. And just please take a moment to identify yourselves to the committee. I'm going to go in the order on my list. So I have Lori Doyle, Dan Martin, Jason Woody, and Mary Quotamine. I don't see that 4th person, so we'll pause on them for now, and we will go to Ann Seacoat. Thank you.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland. We'd like to thank the Moore administration for including a 3% rate increase for FY25. We were struggling with workforce prior to the pandemic, and of course COVID just made things a whole lot worse. And we're seeing the cracks show in our vacancy rates and the number of days it takes to fill positions. You know, in the old days, our biggest challenge was psychiatrists, but now that extends to social workers and even paraprofessionals. So we ask that you retain that 3% increase. It is very needed. Our other ask is in reference to the ASO, the Administrative Services Organization, and it's to ask the budget committees to monitor the transition to the new ASO and to the new ASO's functionality on an ongoing basis. So our current ASO, Optum Maryland, was a disaster from the very first day of their contract. And you probably remember that scathing legislative audit report. And you remember that the department had to make advance payments to providers in 2020 to keep us afloat because we couldn't bill. Their whole system was dysfunctional. So now we have the award of a new ASO, Carolyn. Providers will not be sorry to see the back of Optum as they exit the state, but we are concerned that Optum's already subpar performance will worsen as they near the end of their contract, which is at the end of this calendar year. We're already seeing late payments, inaccurate payments, and our financial situation is so brittle that we can't afford even a slowdown in payment, much less inaccurate payments. So while we hope for better days with a new vendor, we are also concerned that once again the low bid won. That's been the case every single time this ASO has been rebid. I think this is the 5th time. The low bid wins every time. And we've seen a steady decline in ASO functionality over the years. And it's the providers and the people we serve who take it on the chin when this happens. So I just ask that you and your sister committees on the other side of the road, please keep an eye on this transition, and please keep an eye on the new ASO in terms of functionality. Thank you.
Look at you. It's impressive. Pro, you're a pro. All right. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in strong support for full funding for the Behavioral Health Administration. BHA is really doing the work and making the investments necessary to really build out and modernize Maryland's system of mental health and substance use continuum of care. We're really excited for the continued development of the behavioral health crisis response system in the state. This is something we've been working towards for 20 years, and due to the work of the folks at BHA, we're closer than we've ever been to that goal. We're also very encouraged about the plans moving forward on several other really important priorities for the public. You heard a couple of times expansion of the collaborative care model, which really improves the quality of behavioral health care delivered in primary care and pediatric care settings, establishing a network of certified community behavioral health clinics, which are specially designed to provide a comprehensive range of behavioral health treatments, care coordination, and connection to other systems and supports, building out the 1959 program to ensure youth with serious behavioral health disorders are getting access to home community-based high-intensity wraparound services, and a transition to more value-based purchasing to allow more flexibility, coordination, and creativity in the treatment of folks with serious and complex behavioral health disorders. And so these are things that were prioritized last session by the Maryland Behavioral Health Coalition. They were advanced overwhelmingly by the General Assembly. There are strategies to improve behavioral health outcomes and save money and keep people out of crisis. And BHA is really taking seriously the charge and doing the hard work necessary to make sure these policies and programs and services are implemented equitably and successfully. And so again, we're very encouraged by these efforts. We're encouraged by the partnership and strong working relationship between BHA and Medicaid towards moving these programs forward. We're encouraged about the efforts underway to rebuild an infrastructure at BHA and the Department of Health to support this work. And just thank you for your time. Thank you for allowing me to speak. And thank you to BHA for all the work that they're doing. And again, encourage for support for funding for the administration. Thank you.
All right. Thank you. Good afternoon. My name is Jason Woody. I'm the executive director of a nonprofit mental health organization in Baltimore City called Be More Clubhouse. Just to introduce our organization, we work with adults experiencing serious and persistent mental illness to focus on recovery through work. We operate on an accredited evidence-based model utilized by over 350 Clubhouse programs in 33 countries around the world. Through an integrative psychosocial recovery approach, our members access long-term recovery support that assists them with obtaining employment, education, and housing, in addition to daily structure and socialization. So I'm here to introduce myself and our organization, but also we are in full support of the BHA's budget for fiscal year 25. We're very grateful for the administration's support for community-based behavioral health programming, and we look forward to continuing our work with BHA and elected officials across the state to create community and opportunity for adults living with mental illness by expanding the Clubhouse model. Thank you.
Good afternoon, Madam Chair, members of the committee. I just want to add that the person who didn't come up here, who you named, I think was coming with Jason, and she got sick. Yeah. So just FYI. So I'm Ann Seacott, and I'm here today actually representing a bunch of clients. So I will say to start, My clients who are the substance use disorder provider organizations, the Maryland Association for the Treatment of Opioid Dependence, the Maryland Addiction Directors Council, and the Maryland DC chapter of the Society of Addiction Medicine just want to express their gratitude to the governor and the department for the 3% increase that is built into the budget for FY25. They are also grateful that there will be a new ASO. They have communicated with the department. They stand absolutely ready to do whatever is needed to help test the new system, which was the number one thing that, not number one, but it was one of the first things that didn't happen with Optum. And so, they really want to help make sure that this system works. On behalf of the National Council on Alcoholism and Drug Dependence, we want to just emphasize the need to make sure that the full continuum of care is funded well. We absolutely have heard from the Secretary the commitment to recovery supports. It hurts a little to see some revision of dollars related to recovery supports, but we know that everything's in transition. We know we're dealing with difficult budget times. So we also want to be able to work, and we believe we can absolutely work with the department to make sure that the appropriate community-based recovery supports are funded successfully. So thanks, and vote green.
Awesome. Thank you so much. To the panel, do subcommittee friends have any questions? Sorry. Thank you so much for your testimony today. We have two more individuals signed up for testimony. We have Dan Rabbit and Michelle Livshin. And you can proceed when ready.
Good afternoon, Madam Chair, members of the committee. My name is Dan Rabbit. I'm the Policy Director for Behavioral Health System Baltimore. We are an independent nonprofit that serves as the local behavioral health authority for Baltimore City. Local behavioral health authorities are the local arm of BHA, helping to implement programs, oversee the full system of care, and help manage services and quality in the public behavioral health system. We fully support the Behavioral Health Administration budget, and we urge full funding. We're really appreciative of our partnership with the administration and of the historic investments that were made. The rate increase is really important, especially with the workforce shortage that we're facing. That's something we see in our role as a system manager. Is just hard to maintain and initiate new programs because there's just not enough providers, and so that rate increase is really important. We were also very appreciative of the investments in 988 and other crisis services. This is an area of the continuum that has historically been underfunded or wasn't even really always thought of as a part of the continuum 10, 20, 30 years ago. And so these investments are sorely needed and can make a big difference in reducing unnecessary interactions with law enforcement, reducing unnecessary trips to the emergency department and inpatient hospital stay. So we urge that those funds to remain where they are. We really appreciate the innovative initiatives and investments. The Medicaid funding that is coming down the pike for mobile crisis and crisis stabilization centers is also very encouraging, and we urge a favorable report. Thank you so much.
Thank you.
Thank you, members of the committee and the administration, for the opportunity to speak today. I'm Michelle Livshin with Honor Own of Maryland. We represent an affiliated statewide network of more than 20 peer-operated wellness and recovery centers that are funded through BHA. Last year, our network served 8,500 people living with serious mental health and substance use needs, and we're here to support with amendments. Community-based non-clinical recovery support programs like ours are an integral and cost-effective component of the continuum of care. Our centers provide an array of free walk-in services with no diagnosis or insurance required. Trained peer staff assist individuals with meeting their basic needs, health education, enrolling for disability, Medicaid benefits, connecting with treatment providers, and finding housing, education, and employment. Most importantly, we offer a welcoming and affirming community where hope overcomes stigma. Through peer support, we form trusting and responsive relationships that de-escalate crises, divert hospitalizations, and empower individuals towards long-term recovery. For decades, our network has been able to successfully support community members with the greatest barriers and unmet needs. We are very grateful for the provider rate increases, which have boosted our centers' operating budgets. However, most centers remain significantly under-resourced, impacting their ability to meet their full potential for reaching individuals who the system struggles to engage. As a provider recently told us, when someone has burned all their other bridges, they are still welcome at On Our Own. Many served by our centers could meet eligibility criteria for the proposed assisted outpatient treatment program with a $3 million price tag, which we question and continue to strongly oppose. Thank you for providing us with the opportunity to highlight the importance and impact of non-clinical services funded through the BHA budget. These programs achieve great returns on investment and fill the gaps in our system of care with creativity, flexibility, and innovation. Thank you.
Thank you so much to our panel for your testimony. Do any subcommittee colleagues have questions? Okay, seeing none, thank you so much. That concludes the public testimony for our hearing today. Just want to note for our subcommittee colleagues here that there is several pieces of written testimony from a variety of groups in your file. Please, I encourage you to take a look at it when you are able. And that concludes our hearing for today. Thank you.